We are on the ACL prevention course with Sebastiano Nutarelli, so it was a really active course, really practical one. I'm sweating already. So you have a lot of experience. If you can tell the internet the things about you so they can get to know you better.
Yeah, well, thank you for having me, first of all. My name is Sebastiano Nutarelli. I'm a physical therapist. I have a master in biomechanics, and I'm currently pursuing a PhD on ACL rehabilitation at UCD Dublin in Ireland. But as a physio, I practice in Switzerland, where we have some clinics. They are called sports rehab, and we treat everyday patients with ACL injuries. And also, in line with this course, we try to avoid ACL injuries. Okay. So that's why we're here.
So what is your experience with arthrofibrosis? Because I heard that you have some experience with this.
Yeah. Well, first of all, what is arthrofibrosis? Let's say let's call it the stiff knee as a secondary problem after surgery. Usually you have surgery for something else, meniscus or ACL injuries or a serious injury such as a tibial patellar fracture maybe. Patients can develop stiffness, basically an overgrowth of scar tissues that can reduce range of motion, flexion and or extension, and patellar mobility. In the end, the patient is no longer functionally able to do what he was doing. So there is a disability. Our experience actually was born by my personal experience. I had a knee injury myself when I was an athlete. Developed arthrofibrosis, nobody knew anything about it, which is not really that changed as per today, but it was 15 years ago, and I had multiple surgeries in the United States. So I developed some knowledge, and now we imported it. We created a center in Switzerland, which is called the European Knee Arthrofibrosis Center, where we treat patients from all over the world. Basically implementing physical therapy first, all the time if it's feasible, and when it's unfortunately too late, we have a team of skilled surgeons to work with.
Yeah, so I had some patients who developed this, so I think it's really the best if you get to know some information about this, because it really can be a bad thing in rehab. So I know that you have a role in the Arthrofibrosis Association. If you can tell us more about the association and what it is for.
Yeah, the International Artrofibrozei Association, it's I.A.A. There is a website, you can search for it online. If you just digit the name on Google, it will pop out. Was founded by Kali Asher, PhD. She's an Australian researcher that developed arthrofibrosis herself, so in the end seems to be the destiny of whoever is involved. And I joined the association a couple of years ago. There is a board of members. We are 3 of us. The third one is called, her name is Manon Rapp. In the end, the goal of the association is to spread the knowledge and inform patients above all, but also clinicians, on where to get good education and good information, and also what are the best protocols to try at least not to favor the arthrofibrosis onset and to limit possibly its evolution. Okay, thank you. So moving from the arthrofibrosis to the prevention of the ACL, if you can tell us some protocols that you think are efficient for preventing. Yeah. Thank you for the question. So the interesting thing, as we just saw in the course, is that we do have a lot of effective protocols published since the 90s, the 80s, but the reality is what we care about are not the single protocols labeled with different names, but the core elements of these protocols. So the pillars of each protocol should be, if you want to design an effective ACL prevention program, strengthening, hopping, jumping and landing as a session following an initial warm-up session. So you need to warm them up dynamically, have them jumping and landing so that they can improve their landing strategies above all, and this is especially true for the young female athletes. And then some strengthening, and then other elements such as the flexibility, stretching and cardio, etc. can be integrated, but really the core elements are the ones that I just listed. And then if you search for protocols, if you want to read them, for instance, the sports metrics, the nut control, the PEP, and etc. All these ones are valid, but there is a publication on JOSPT, the Journal of Orthopedic and Sports Physical Therapy, I think in 2023 by Amelia Rundal and colleagues, listing all of them and framing for what they are efficient, for their work. It could be for a different sport or sex.
Regarding the peace and love protocol, so we have this discussion here in Romania if we should or should not use ice. What do you think for the anti-inflammatory procedures?
Depends where you are, but let's say you're in inflammatory phase, which is when historically the eyes, then rise, then police or police, use the name that you like and the pronunciation you like, and then the peace and love came up. It's the same thing, really. The problem is that inflammation is needed, it's good. We need inflammation, otherwise healing doesn't happen. So the whole idea of, I don't want you to use ice, otherwise you impair the inflammation, hence healing, makes sense. unless you're having disproportionate inflammation, which by the way is the foundation of the onset of arthrofibrosis. So the risk versus the benefits, I don't like playing with the patient evolution, clinical evolution. To me, you do ice, especially at the initial phase, 20 minutes on and at least an hour off, and this is a guideline, there are publications on it. It's not going to impair your healing, it's going to control the metabolic reaction, which means you have inflammation, but you want it under control.
Okay, thank you. So in regarding to prevention of the ACL traumatism or a rupture, does the rest of the joints matter, the hip, the ankle, or we should focus just on the knee?
Well, if you focus on the knee, you're not going to succeed. That's the point. The ankle is distal. I would say whatever is distal is a losing game. Obviously, we want to have a strong ankle in terms of the afferent muscles, but we have to look above the knee. So the hip, probably everything is about the hip. So strengthening the abductors, the adductors, and the control that you, the athlete or the patient, has on the sagittal plane of the lower limb, which is all about the hip. Is the key element. Clearly you need a strong quad and you need balanced strength, hamstring in relation to quad and etc., abductor ratios and so on. But if the hip is weak, simply your leg will wobble on the sagittal plane, which is not good for the knee.
Okay, thank you. So in the end, if you can tell us some websites or some courses that we can look for to find you and your information.
Well, in Romania, where we are now, I think if you look at www.tomavasilescu.ro, you will find the courses we are organizing here, in which I'm teaching, running courses, and some other colleagues that are clinicians and researchers. If you search for my name online, you will find things that I'm doing in other countries, but I'm not sure it's that conveniently located for whoever lives in Romania.
Of course. Thank you. It was a great interview.
Same. Thank you very much.
Thank you.